Okay, so good morning, everybody. I'm Robin Strongin with Health Dame, and today we're going to be talking about a topic that really requires, I would say, more than one conversation. We're going to be talking about mental health, which, as everyone knows, is a global challenge. It's national in scope, and it's also deeply personal for an individual who is affected by different mental illnesses and mental health illnesses and the people who love them. And today I'm really pleased to welcome my friend and colleague, Nora Super. And Nora, I have to say, I may slip and say Norma because I just got off the phone with a friend named Norma for about an hour. And I really hope I don't, Nora, Norma, so I may, twist up. But Nora Super and her husband, Dr. Len Nichols. And they've agreed to share their experiences of what it's like to live with recurring severe depression and what it's like to live with someone experiencing this condition. Both of you guys have selflessly shared your experiences in a number of forums, including articles, which I will post when we post the conversation. You've also written about and shared your analyses on policy improvements, economic ramifications, and the devastating impacts of employment discrimination and stigma. And it really is my honor to be having this conversation with you guys today. So, you guys have been at this work and other work. I'm going to talk a little about your aging work in aging, not your aging experience per se. We all do that. But it's a high level. And again, I'll write the bios on the links, so we won't be spending a lot of time doing that. But at a high level, Len, I believe that you are Professor Emeritus at the College of Health and Human Services at George Mason University, as well as serving as a non-resident fellow at the Urban Institute's Health Policy Center, which is a think tank here in Washington, D.C. And Nora, as I said before, you are a national expert, excuse me, on aging issues, aging policy, dementia, long-term care, retirement policy. And back in 2014, President Obama appointed you as executive director at the White House Conference on Aging, which I imagine was an amazing experience. And I'd love to hear about that at some point. A lot of work. But you've also been in the department in leadership roles of Health and Human Services, AARP, Kaiser Permanente, and US Aging. So you've been extremely busy, but actually, I think my favorite gig for you was when we got to work together for the legendary Judy Miller Jones at George Washington University's National Health Policy. And apropos to today's conversation, you guys are working together on a book that you're writing about these experiences. When about do you think that'll will see the light of day, or is that at the very beginning?
We've written a lot of it, so we're hoping
Oh,
to um, be able to get it out within, well, I guess we're almost into 2026 now, so sometime in 2026.
okay. All right. So not too far away. We're close. That's exciting. So I think to kick things off, I think it would be helpful, Nora, for you to kick off what you want to share about what it's been like for you to live with, severe depression over the years. And as I said before, I'm likely to interrupt, but go for it. And then well, I have a bunch of questions for Len as well. So, but why don't you kick us off?
Sure. Thanks, Robin, and thanks for having us today. This is an issue that's really important to us and our family and has impacted us greatly. But our hope is really in talking about our experiences that we can help others that are experiencing mental illnesses, as well as family members who love people experiencing mental illnesses. It can be a very lonely experience. And so I think learning, as you know, similar to living with someone with living with dementia.
Yeah.
And I think that, our hope is to really help people understand that they're not alone and that there are many people experiencing this and that we have to work together to really try to improve the system. I first became severely depressed over 20 years ago. So it's been a long journey that we've been going through. My initial major depression was really triggered by Hurricane Katrina.
Hmm.
Now, as you know, we live in New Orleans now,
Yep.
but back 20 years ago, we lived in the Washington, D.C. area, and really the two of us spent over 30 years there. Um, but back at that time, and my husband Len is much better at dates than I am, but it was 2000 something.
2005 was Katrina, but your depression really kicked in around Christmas.
Okay,
Okay.
so 2005, when after Hurricane Katrina, and I just saw all the devastation in New Orleans, it really triggered into me a deep depression. And we traveled to New Orleans after Katrina to deliver a car to someone in need, as well as many presents for kids who had been impacted by the storm.
Oh, wow.
But I started to feel my depression at that time. My mind just started spiraling where I can't focus on anything. I can't stop talking about something that I'm worried about, and became more and more depressed to the point where I finally became suicidal.
Right.
And unfortunately, my depression is characterized by becoming suicidal. And I really have learned a lot about it. I will say, Robin, I didn't talk publicly about my depression until many years later, after I experienced my first depression and several hospitalizations and suicide attempts over the years. But what really made me want to speak publicly about it was the deaths by suicide of both Kate Spade and Anthony Bourdain. And I think what happened after was I heard people talking about depression and saying, how could people who are so successful be depressed? You know, they had so much going for them. And how could they do this to their families? And this is just such a terrible thing. And I thought, you know, these people talking about it really don't understand depression. So when you're caught up in a cycle of depression, you believe people will really be better off without you. Your mind is distorted and is telling you things that aren't true, but it's really that you're a burden to your family, that they would all be better off without you. And it tricks you into thinking these things that aren't true. So it's really a disease. It really is. And it's an illness that impacts your mind, and you can't think straight anymore. It's not like someone can just say, snap out of it, like share, you know, but more that you really need long treatment and help along the way. So that has been our experience. Several hospitalizations, um, several suicide attempts throughout the way, and my husband has been by my side all along the way, which I'm really grateful for.
So, Len, what is it like from your perspective? I mean, dealing with the hospitalizations and so on, what have you learned from that that you would like to see perhaps change so it can move the needle to we're not nowhere near where we need to be in terms of access and care and policy, but from your perspective, what can you share with us?
Well, thank you, Robin. I would say the single most important thing is that families need to be taken into account more in a transition to and out of a hospital. We've had a number of experiences over these years, and I would say the most recent one where Nora had a spinal cord injury, and so she was in a rehab hospital for over a month. The difference in the way the rehab staff prepare family for going home
I see.
compared to psychiatric staff preparing family is just stunning.
Wow.
The last 3 days of a rehab stay, they just work with the family member. This is how you transfer people to a bed. This is how you transfer people to a chair. This is how you do everything that's got to be done on a daily basis. And you don't leave until you know how to do it. Okay. And in New Orleans, how to back downstairs with no elevator just in case the hurricane comes, right? I mean,
Oh,
they
wow.
teach you everything. Well, for a psychiatric inpatient stay at a hospital, typically there's no conversation with the family. If there is, it's something like, well, do you know a psychiatrist? Can you make an appointment within 7 days? Okay, goodbye. They never tell you the fact, which is that the average patient is more likely to attempt and succeed at suicide right after discharge than the general population by an order of magnitude. So you don't know how dangerous your loved one is. Typically, a family member isn't told anything about that risk. And so you don't know. When a hospital discharges somebody with a broken leg, you think their leg is set, they're hospital discharged from pneumonia, they're cured. They're not cured for depression. Depression doesn't go away that fast. And I'll just say very quickly, there are a lot of tremendous, wonderful health professionals in the mental health field, and God bless them all. But the legal restrictions on how they behave and what they can tell you and all that stuff is just
Is
it
that
puts a
what the
burden on the
issue
family.
is? It's a legal restriction that,
Well, I think they're afraid of liability, and so they don't want to act like the patient's as dangerous as they are when they're discharging them. And it all gets balled up in this issue of it's a very complex thing to
sure.
decide when someone's a danger to themselves or others. All I'm trying to say, Robin, is my first point. The family needs to be part of the discharge conversation. Is she ready to go home? Okay, if she's ready to go home, what do I need to be able to do to take care of her? And what I'm saying is, compared to what we got in a rehab hospital, it is stunning how little preparation there is for families bringing home someone who is still a danger to herself.
I actually remember writing something after my first experience, believe it or not, when the very first Apple iPhone came out. There was this line wrapped around in the shopping mall. That was in the days we went to shopping malls. And the staff came out and offered bottles of water because people had been standing a while, right? You went in when it was your turn. You sat down with one of the Apple, from the Genius Bar types, right? They took the phone out. They went over and over and over. They didn't let you leave till they were sure you knew how to work it because no one had an Apple phone before. And you were instructed, you were given easy to understand directions. It was boxed back up, and you went on your way with your phone, which you understood how to use, your water so you wouldn't get dehydrated, and so on. I went home, was very excited. That evening, my son took a terrible fall, and we ended up in the emergency room. We ended up in the emergency room where the only water available was a public fountain where there was vomit in it. Okay, there
Oh
was
gosh.
chewed up gum, there was spit out food, and there was vomit in it. When we finally went in and, we left with some medical equipment and this and that, no one explained it. The contrast between my experience in the afternoon and my experience with serious illness and so on was like, this is ridiculous. And I understand all of the financial incentives and all, but it's like, and now, we, okay, so this is definitely an issue. Are there efforts to try to improve? What can we do to try to start to fix that? Are there policies in place? Is it a state issue? Is it a national thing? It's legal. It's all of these issues. What?
Yeah. One of the things that I want to say is that we know people with mental illnesses have really fought some court battles over the years and have been, disenfranchised many times, that people have been, put away, as you may
Sure.
say, for a long time and feel like they have no rights to get out of the hospital. So we understand that and don't want to say that these rights aren't important. So it does become legal, many of the issues there. But I had experience once where I discharged myself. I, didn't want to stay in the hospital any longer. And so I petitioned that I could get out against medical advice, as they call it. And I had the right to do that. Now, I'm also smart enough, not to say other people aren't, but I understand the healthcare system enough to know what it is the professionals want to hear. So if they ask me, are you
Oh,
suicidal? Do you have any intention of harming yourself? I said no, because I wanted to get out of the hospital, even though all I thought about at the time was how I was going to end my own life. And so I think that and as my husband is saying, what happened was I was discharged before I was ready and sent home with a family member and basically told good luck. He had a doctor actually tell him, well, we'll get her into a day program and on Monday. This was on a Friday, but all you have to do over the weekend is make sure you watch her like a hawk so that she's still alive by Monday. I mean, can you imagine? And so we really think that the family needs to be more involved, and the laws are dependent on the state. So the District of Columbia has more rights for individuals living and staying in mental health facilities than, say, Virginia does, where I spent um, several hospital stays in Virginia, where they were more aware, more sympathetic to the needs of family members. But as you say, it's still not like a consumer experience. And just because it's our healthcare system, which is messed up. I mean, I think there are so many times that you hear about people all over in all kinds of healthcare situations where family caregivers are sent home and asked to do really complex things for the people that they're caring for. And, with the billions of dollars that we spend on healthcare in our system, truly we have to be able to shift some of our resources so that we're helping family members who are really caring for people once they get discharged.
No question. Absolutely no question. That is something that I'm going to come back to in a minute. But what I do want to ask is, I do know that there's been some movement with treatments and things that could be helpful, things that were helpful to you. And I know you've been writing about ECT, electroconvulsive therapy, which has an unfortunate history in terms of what people may think about it. And it has a long history, but it can be helpful to people. And I know we get wrapped up in stigma and shame and all of these issues in general, but say a little bit about ECT. I know there were some issues here that you wanted to share.
Sure. Thank you, Robin. Yes. I mean, for me, having been in the hospital, it was what, 7 times over a course of 5 months or something like that. And not a single health professional mentioned ECT as an option to our family. It was a family friend who was a doctor who
Mm-hmm.
told us, you may want to think about this. And it does have stigma attached to it. I mean, a lot of it goes back to One Flew Over the Cuckoo's
Sure.
Nest and Jack Nicholson, where, and there were abuses in the system. I've had mental health professionals say they used to do it without any
Anesthesia.
anesthetic and without, just do it while people are laying on beds in the hallways and things. But for us, it really was a godsend. It made the huge difference for me. And each time that I've been severely depressed, really the only way that I've gotten out of it is because of ECT. And it's a short procedure. It only takes like 5 minutes long. They do have to put you under with general anesthesia. But for me, it's like my brain has been jump started.
Yep.
It's like
Yep.
certain neurons are not connecting until they do this. And then I'm better within like 4 treatments. And it's really something we want people to know about, as they shouldn't. It took me a long time before I would even admit to anyone that I'd had ECT, because there's stigma against mental illness, but most especially around ECT. And everyone thinks, oh my God, you have, you know, um, electric stimulation on your brain. And I think, yeah, that's what I needed. I was in such a funk that I couldn't get out of it, and I needed some sort of electrical stimulation to get me back into a good place. So I don't know, Len, if you want to say anything else about ECT, maybe how often it's
Well, I
used.
was going to say, Robin, for this book, we've done some research and we discovered a couple of what appear to be facts. Okay.
Okay.
No, number one, about 26 million people a year in the United States have a major depressive episode. As far as we can tell, about 100,000 get ECT. Now, I'm in no way arguing ECT should be for everyone.
Sure.
But I will notice ECT is twice as effective as a percentage of success as the typical pharmaceutical. And yet pharmaceuticals are prescribed without thinking about it really, because it's an easy thing to do. And they are effective. Let me be clear. They are effective for some
Sure.
people.
Sure.
But when you're in this deep funk like Nora gets in, there's nothing that's going to work except ECT. So I think that, and we learned from conversations we've had with psychiatrists that within the psychiatry profession, there's kind of a stigma, partly because some psychiatrists just don't do it, and partly because they know the patients are afraid of it. And so they don't want to mention it to scare the patient. There's this whole notion of treatment resistant depression, and that's really where Nora and a number of her colleagues are. And for them, ECT is a godsend. And so our fundamental message is A, we should talk about this more often. The
Sure.
fact that she was hospitalized 5 times and no one ever mentioned it except our
That's
friend in New York.
astonishing.
Well, thank God for her. And
Yeah.
by the way, the article she gave us was from the Atlantic, which had this
Wow.
wonderful history of it. And then when we finally get to a psychiatrist in DC who will do it in 2006, he gives us the same article from the Atlantic because it's perfect at calming you down about what's
Yeah.
possible. So anyway,
Are
we
you
should.
able to receive the treatment outpatient, or do you have to be
I am. No,
inpatient?
you don't have to be in the hospital. I still have it now. As Len alluded to as we were talking, my last suicide attempt unfortunately ended up leaving me with a spinal cord injury,
Mhm.
and so I'm paralyzed from the waist down now. And as a result of being so severely depressed that I attempted suicide again, my psychiatrists have recommended that I use ECT on a maintenance basis. So I go every 2 months now and receive ECT, and it's an inpatient procedure. I mean, outpatient procedure, excuse me. I have had comparisons to other procedures where it is sort of, we go in very early in the morning and they do it sort of in an area of the hospital that isn't used that often and all these things. There's stigma in the hospitals. And I think part of it is it's not reimbursed really
Well, I was going to
highly.
ask about that
Yeah.
too. Yeah.
And so I think that's part of the reason why they have to do it while they're sort of not in the way. But it's also because it's a mental health issue, I think. It's just not treated the same way our physical conditions are treated in our hospitals.
It's just breaking through this stigma on these issues that I'm determined to do. It just makes me crazy. So many people need so much help, and we know some of what we need to do. We certainly need to be doing a lot more when it comes to understanding just the physical disease and how we might make better, inroads in terms of cure, and treatment. But my God, I mean, the stigma stuff we can work on. And I'm going to circle back to that too, because the other issue I wanted to talk with you about is, and it's related to this, is employment. I mean, so many employee applications require certain questions, certain jobs, et cetera, et cetera. And I know you've experienced some of this as well. Do you feel comfortable sharing some of that?
Sure, I'd love to share that. As you noted, I've had a successful career. I'm very proud of what I've done over the years, but I was doing all this while I was struggling with recurrent depression. And for many, many years, I didn't disclose to my employer that I had depression. I was too afraid that it would impact whether or not I got promoted or hired for a
Even
job.
though all these jobs are in healthcare, mind you. So of all the
Absolutely.
places where you'd think there would be some recognition. Yeah, yeah,
You would, but I was afraid, and
of course.
it wasn't an unjustified fear. Things happen, and
You bet.
one thing that when I applied for the White House job, you have to go through high security clearance to be able to work in the White House, and in the questionnaire that they have, and mind you, this is done by the FBI, so you can't lie about anything. They're going to find out. And one of the questions asked if I had been hospitalized for a mental health issue over the past 7 years. And fortunately for me, it had been longer than 7 years. I've had times in my history where I've been very stable for a long time. And
Sure.
fortunately, this was one of those times. If I hadn't been, then I would have had to disclose that I had been hospitalized and probably wouldn't have been able to get the job. I have a friend who has bipolar disorder who had applied for a job in the White House, and she really thinks the fact that she disclosed her bipolar disorder is the reason why she didn't get the job. I have friends who have depression and have high security clearance and who don't even take antidepressants because they're afraid that their security clearance will be revoked. Now, I don't think it'll be revoked because you take antidepressants today. It's much more common for people. But, we were just watching, in the wake of Robert Redford dying, we've been watching a lot of his movies, and we watched All the President's Men
Oh, yes.
the other day, and they had the
Eagleton.
Eagleton story about the vice presidential candidate running with McGovern, who had to step down because it was disclosed that he had ECT. So, it has been in our national spotlight as something of like, we think something's wrong with you if you have mental health care in our country. And it's really sort of having this independent spirit of, well, people should just buck up and handle it or be happy for what they've got. And as I described in the beginning of us talking, it's a real illness. It's not something that you can just say, oh, okay, I just need to feel better tomorrow. I mean, it really takes over your whole brain and you can't function. I mean, in my case, I can't work when I'm severely depressed.
Sure.
My mind is too messed up where I can't focus on things and I can't get things done. Now, over the course of the years, I've been able to disclose to my employers that I suffer from depression sometimes and I've had to take time out. And, as I felt more comfortable with it, they felt more comfortable with me too, because generally I know how to manage my episodes. Whereas I said, ECT has been a real godsend. So I
Sure.
can tell my employers, look, I need to take some time off. I need to get this treatment. And once I get this treatment, I'll feel better. Sometimes that made me rush too much to try to get well to prove that I was well. But I think for the most part, as long as I was more open with my employer, and because I had already, now I have to stress, it was because I had already proven myself
Sure.
as a successful employee who worked really hard, then I had that a measure of trust with my employer where I could share the information and know that they would trust that I'm going to get better. But, a lot of people don't get that opportunity because they don't have access to the treatments that will get them better. I mean,
Sure.
another thing that I'd like to talk about, Robin, and I don't want to
Sure. No,
hijack,
no, no. Go,
but
go,
I
go.
think one thing we didn't mention when we spoke earlier was just the fact that so many insurers don't take so many medical professionals, psychiatrists and social workers and psychologists don't take any kind of health insurance now. And there are a lot of reasons for this, but the end result is it makes mental health care something that's just available to the affluent now. Really, if you don't have insurance, I mean, Medicaid will cover it, and behavioral health, I think, is one of the, biggest forms of treatment that Medicaid does provide. But in between Medicaid and regular insurance, most people can't, the health professionals don't even take insurance. And so you're left with having to pay out of pocket for what can be very expensive treatment, $200 an hour to see a therapist. And if you're seeing them more than once,
Oh, it
once a
adds up
month,
very
then the
quickly.
cost can really be, yeah, it adds up very quickly. And through our research, we really found that the reasons why mental health professionals don't take insurance is frankly because they don't have to. Insurance, as I'm sure you've discussed on other programs or should in the future, is just really frustrating
Oh,
for
yes.
providers. There are a lot of hoops they have to jump through. They have to deal with prior authorization. They feel like they're having to prove themselves and their worth for the insurance to get things covered that they know need to be covered for their patients. And in the case of mental health in particular, it's typically been discriminated against by insurers. In the past, they really didn't cover a lot of mental health. And so the mental health professionals because there's such demand now and there are too few mental health professionals, they've found that they can charge out of pocket and people will pay for it and they don't have to deal with insurance.
So it
So,
leaves a lot of people without any kind of ability to access the care just on affordability. And, related to the affordability question is someone who's helping care for the person who's undergoing treatment. I imagine that creates quite a challenge. I mean, I know personally with when Brian was sick, and I was a full-time caregiver for him, that means you can't work the same way. And so you're not bringing in the income. And I imagine, is that part of what you guys are addressing in the book? Is sort of the whole, the dyad of the two of you together and what that looks like? I mean, there's a lot of complexity there, and it's kind of a bit of a spiral. Financially,
Yeah.
emotionally, everything changes, right? I mean, Len, you're
And
living this.
no question, Robin. And what I would say is, and we think about this and talk about this together a lot,
Sure.
we are among the lucky
Sure,
because we
understood.
have resources in education and we know people like you and we understand how the system sort of works and we know how to work the system, right?
You have a
But at
fighting
this,
shot at it, yeah.
but we have a fighting shot, and just we just think about it all the time. What about those people who don't have all the advantages we have?
Screwed
And
completely.
so I
Pardon
look
my
at the
French.
insurance situation as eminently fixable because, I'm a policy wonk, so anything is
Yeah,
fixable.
yeah.
But it does have to do with changing both awareness and attitude and some rules. I honestly believe that deep inside the bowels of insurance companies, A, there are good people, but B, there are actuaries who still think about Woody Allen and all those people who go talk to a psychiatrist for no good reason, just to have someone to talk to.
Hmm.
And the problem, the analytic problem is they don't understand what managing a chronic disease like depression is like compared to a curative disease. And so, since you can't cure yourself, well, then they don't want to deal with it. Well, that's just the wrong way to think about this.
Sure.
Nora is a walking example or a talking example of someone who fundamentally can function at a very high level if you surround her with the appropriate support at the appropriate time. And anyone would agree to that who's seen her perform. At the same time, there's no question that insurers would rather not have to deal with this
Right.
at all. Now, I will say in our situation now, we have good insurance for her. We hope it continues. We're pretty worried about what's going to happen. She's a marketplace purchaser, and some people are trying to blow that market up, and
Yes.
that could be bad.
yeah, but we still pay out of pocket for my psychiatrist and
We
my
pay out of
therapist.
pocket for psychiatry and for therapy, that's right. But for ECT, it's covered.
Hmm.
Mhm.
Okay, and that's a big
Hmm.
that's a big thing.
That's a
So
big
anyway, I'm
one,
just
yeah.
saying we need to change attitudes about what managing chronic condition is about. We need to change attitudes about actually having an adequate network. We don't enforce those rules very effectively, and the combination of that, and then you got to listen to the psychiatrists. They're not wrong about the hoops the insurers make them go
A
through.
100%. Yeah.
So
I
anyway,
faced those with
there are
Brian. I mean,
solutions.
it's a nightmare. It's really a nightmare. And and my fight with him was on, because he had Lewy body dementia and there's hallucinations and delusions, and he thought he was being eaten alive by a tiger, and nothing I could do could get him to understand that that wasn't literally happening. And then I started playing music, and that sort of got his brain, I stopped with words because the brain and music anyway. And I was begging for this one, and it became a whole prior authorization. And again, I got very New York on the people, and eventually, eventually I got it for him. But I mean, it took quite a bit of doing, and quite a bit of getting a million doctors involved in it. It almost did me in. That one thing almost did me in, but I was not going to let that happen. But I do think the awareness and being out in the open, that's why I did so much writing about dementia and, Brian being on the younger side and because people really don't understand what the illness is like. They think they know because of movies, and journalists don't always get it right. And I think there's so much work we can do with how people are understanding what is mental health, what are these innovations, what we need to do. We just don't talk about it. We do, like you said, we just don't talk about it. And that makes it really hard to push the needle forward. And, I am committing to doing more on this issue because I can't tell you how many people that I personally know right now today are struggling with not the exact issues of depression, but schizophrenia, other issues that are really impacting not just their life, but the family. They're in such crisis, and to be able to get help, to be able to find a way to figure out what you need, how to make it work, it is a full-time job. And it doesn't have to be that way. It doesn't have to be that way. So in the book, are there some tangible suggestions for what to do policy-wise? Because, give me an advocacy campaign and
There's
let me loose.
something some things that we've thought about to deal with the, lack of medical professionals in mental health care and the
Sure.
affordability issue is we've found some success in some places with peer support, where you can actually
Yeah.
train people who are living with a mental health condition but are in a good place to be able to provide support to others that are going through it. And this is something that can be very therapeutic. I mean, for me, writing and talking about my illness is very therapeutic. And if I can help others and say, I really understand what you're going through. And a lot of times that's really what people need. They don't have to have a medical professional that's highly trained and very expensive, but rather someone that can be supportive to them while they're going through a crisis. It's really important that people aren't alone.
So, oh, go ahead.
Well, I was just going to say there are other treatment options. As we said, antidepressants are prescribed pretty quickly, but there are other things that people can do, things to help people, as we focused in the aging community about things like social isolation. Well,
Sure.
that's a real predictor of mental health issues for people that are from all ages and walks of life. If they're isolated, they're more likely to suffer from depression or anxiety. And, there are programs that doctors can prescribe. They do much more in the UK than they do in America, such as social prescribing, where they'll actually, encourage their patients to go out and be with other people. There's a classic story in one of my favorite books called Lost Connections that talks about a nurse that had been depressed for years, and her doctor prescribed that she be part of this neighborhood group doing a community garden. Mm-hmm. And it was just a wonderful therapeutic impact where these people that were suffering from depression all came together and were doing something together that got them out of their minds, that got them thinking about
So this
something
is an
that was
issue I
helpful.
know very well. I know Dr. Jeremy Nobel at the Foundation for Art and Healing, and he works, I mean, I know Vivek Murthy, the previous Surgeon General, came to him, and he was instrumental on the social isolation and loneliness work. I actually interviewed him for Health Day, and I have my conversation with him and all of this. And there's a researcher out, I want to say in Utah, I forget her name now, Holtz, Julie, I can't remember, but it's
Julianne Holstead, yeah.
yeah, where the equivalent is smoking however many packs of cigarettes a day is what isolation and loneliness. It's not healthy for anybody, no matter what your age. And so these are things we can fix and make
And
a
I
difference.
would just suggest, Robin, same song, second verse for family members.
Yeah.
My church started a support group for caregivers.
Okay.
And I cannot tell you what a lifeline that has been for me. And I remember going in a hospital one time with Nora and seeing a family member bring somebody in, which I could tell by the body language was the first time.
Yep.
And so I actually happened to know the CMO of the system. And I called him up and I said, we could start a support group for family members, and I'd be happy to lead it. And let me tell you what I've been through. He was for it. The CMO of the hospital was for it. But the lawyers at the system level were afraid of having an untrained professional reach out to family. So all I'm trying to say is, yes, let's set up this support for families as well. because just being in a room with other people dealing with the same thing is worth gold, whether
Oh
you're
my
gardening
God.
or flowering or whatever. Yeah.
It really is. And that we can do, and there are organizations and ways to where the hospitals or the medical setting that's afraid of their liability, Michigas, can, recommend you go here for the support. And
Exactly. Here's
don't
a
even try
brochure.
to fix that because that's just an uphill situation that we can work around. And I can't imagine there isn't a fix for where we started with having the family involved post or discharge, because there are, you know this better than I do, but injury prevention funds that are set out for medical liability. Like, there are ways and models to be able to set something up that would take some of the pressure off the legal issues for the entities to enable the objective of what you're sharing here today. There has to be a way to fix that. And there are probably models, maybe in other, you know, areas, but that might have some utility in this space. And again, just the day-to-day stuff with stigma, I think we're getting better as a society, at least here in this country, of breaking down certain stigmas. We have a long way to go, but my sister used to be an audiologist. She worked primarily with elderly folks, but part of her training was, of course, in school, like 1,000 years ago, with little kids. And it used to be nobody wanted to wear hearing aids. They didn't want things in their ear. It was a stigma. They just didn't want hearing aids. Well, now people have everything sticking out of their heads. People wear all kinds of stuff, the headphones, those wireless things. Everyone looks like some kind of robotic thing with a million things. Now the little kids don't care. They wear them. They think it's cool to have stuff in their ears. They look like everyone else. So it's a bizarre thing how we sort of can break down stigma, but if we're creative, I do believe we can figure so, and just talking about, you couldn't even say breast or cancer back in the day with Nixon. I remember, didn't Mrs. Nixon go public and it was a big to do back then? Like, somebody said, the C word out loud and in full, and it was, oh my God. And,
Yeah, it's a good point.
Having been a caregiver, there isn't a body fluid I won't talk about. There is, my hands have been in them all, and I have no problem sharing, my experience if it can help somebody else. And, Brian was very open and okay with me sharing. And I do think people never even really knew about Lewy body, and it's starting not because of Brian and me, but because of so many people. And why it's important, because folks in the research community with innovation, they don't even when they don't think there's a market to look for some of these research cures, because people don't know about the disease. So what happens? On Brian's death certificate, it was coded as Parkinson's, because yes, it's a part, right? So it looks like the numbers of Parkinson's patients are really high, but not Lewy body. So there's not a real assessment of them. Anyway, that's a whole separate conversation.
Yeah. And
But
unfortunately, that side's just getting worse in terms
yeah,
of research. So,
yeah. So, and we've got to let people know that there's just this need. And I like your approach, Nora, with, not everybody needs to be seeing MD, PhD, neuropsych experts, from on high. Sometimes there are a lot of highly trained non-medical professions or other professions or what have you that can be helpful in the big scheme of things. It's a big set of needs that we need to figure out a way to start filling for. But the best thing is you guys sharing, and I'm so deeply appreciative. And before I let you go, I'm going to ask you the question I always ask about the song. So who's going first to tell me their favorite song? And I'm going to write it down. Nora,
so
you
we
first.
came up with a song together
Oh, yay. Okay, I
that we
love that.
thought would best reflect what we've been talking about in our
Great.
20-year journey here. So it's "Help" by the
Oh,
Beatles.
perfect.
So
I love it. That
I love
just sums
that
it
you're
up
doing a
beautifully.
playlist. I love that you're doing a playlist and can't wait for you to share it.
I'm going to share it by the end of the year. It's just such a breadth of, it's fascinating how people select their song and why and what it means. And let me
Yeah,
just,
this one we really liked because it's, really focuses on I don't need help just by anybody. I need it from you. And, it's sort of a bigger you that we're trying to talk about, but also that, when I'm feeling down, I need help to get by. And so it just seemed like the perfect song to
it
capture
really
the
is.
period that not, right now we're not waving in crisis that we need help, but we've certainly been there. And we know many people are also there when they're in a mental health crisis, and that, there is help out there, but we have to really come together collectively as a nation to really think about helping people. And you talked about stigma, and I think, after the pandemic, it did sort of help some because so many people experienced mental health
Yep,
conditions because they were isolated and lonely. And so I think that we really think that help is out there, but we need to work together to come up with new solutions and new ways of thinking about helping people with mental illness.
I
I would
agree.
also just point out that one line, I do appreciate you being around
Yeah,
because that's it. It's about being present. It's
yep.
about being present, whether you're for the loved one that's suffering or a colleague who's caring for somebody or just somebody you see having a hard time at the checkout counter and you know exactly what kind
What's
of
going
depression
on?
they're in and you just want to get the clerk to back off and give them a minute. And so you can do all those things every day.
Amen to that. What a hopeful note to end on, you guys. Thank you so much for your time, and I'll follow up. But in the meantime, have a wonderful day. I know it's raining in New Orleans, but you still have better coffee and beignets and things than we do. But so at least you get to enjoy that. So I'll be in
Come
touch.
visit. Come visit.
I would
You'd love to
love it's
visit.
one of
We have
my
this
favorite
wonderful.
places. I don't I hope you have an extra bedroom because I'm taking you up on it.
We do. We do. Come
Okay.
on down.
Awesome. All right. Thanks,
Thank you,
guys.
Robin.
All
It
right.
was a pleasure.
Thank
Okay,
you. Bye now.
bye-bye.